Hello, good afternoon, and welcome to the third session of today in the Cairo Knowledge Exchange Research Incubator, the session on opportunities and challenges in working with linked datasets. My name is Lucas Hofstetter. I'm the Manager Research and Development at Caris New South Wales. And I would like to start session by acknowledging the traditional custodians of the land that I'm joining from today, that is the land of the Gorogo people, and extend my respect to elders past and present from this land, as well as from all the other lands that are represented by our attendees here today. Please feel free to add the lands that you're joining from today in the chat. I would also like to recognize the significant contributions that First Nations carers make to their communities and acknowledge any First Nations carers joining us today. Before we get started, for some of you, it might be the first time to encounter the Care and Knowledge Exchange. A few words around what we are. We are a research translation project led by Caris New South Wales with funding from the New South Wales Department of Communities and Justice. Every year we do an event like this, the Research Incubator, an event that focuses on bringing together researchers, carers, policymakers, and practitioners to share the knowledge, learn from each other, and improve outcomes for carers by interacting with each other, learning how to best translate our knowledge into practice. Today's session is called Opportunities and Challenges of Working with Linked Datasets, and I'm very excited about the high quality panel that we have assembled to that. It is a topic that it becomes more and more prevalent, and we saw in presentations on the first day as well of the Research Incubator, so yesterday, that there is a high interest in what's going on in this relatively new aspect of research. To explore working with linked datasets today, we have our excellent facilitator, Associate Professor Ben Harris-Roas. He's a researcher and educator with over 20 years of experience. His work improves access to healthcare for carers, for people from multicultural backgrounds, and people living with disabilities. Also on the panel is Associate Professor Prayapon Sasupkan. Her work over 2 decades has generated data-driven evidence that addresses health inequities faced by people with intellectual disability. Her pioneering work transforms statistics into actionable insights that improve healthcare outcomes for our vulnerable populations. Also on the panel is Associate Professor Margot Barr. She's the program head of the Health Systems and Equity Research Program at the International Center for Future Health Systems at UNSW. She's an epidemiologist with experience in public health, health service research and evaluation, survey and cohort management, and analysis of large linkage data. Her research in carer health outcomes was undertaken using the Sachs Institute's 45-NUP study, and with a cohort that was linked to health administrative data, and she'll be speaking about that experience today. And last but not least, we've got Andrew Hayne, who is Professor of Biostatistics at the School of Public Health at UTS. He works across a wide range of research content areas, from maternal and child through advanced care planning. His research includes adolescents going through drug treatment with the Ted Noffs Foundation, linking different data sets, looking at refugee health with an NHMRC grant, and how the health of blood donors is affected by blood donation with the Australian Red Cross Lifeblood. We are aware that some of the topics that we discuss might be challenging for carers, and therefore we do have a well-being officer working with us today as well. The moderator in the chat will provide a link so that if something would upset you or you feel that you require someone to talk to, please contact our dedicated well-being officer. That's so much for housekeeping. I will now hand over to Ben, who will facilitate this exciting panel for us.
Uh, Welcome everyone. Great to see you all. So the format for this afternoon is going to be I'll speak a little bit about what data linkage is and what some examples are that have involved um, linkage studies for and with carers, and then we'll have a bit of a panel discussion with our experts, and then I want to open it up a little bit and cover the issues and the queries that you've got as well. But before we begin, I did just want to take the opportunity to share a brief poll, if that's okay. It's going to be a Mentimeter, so you can pull out your phone or the link will be posted in the chat as well. And what I wanted to get a sense of is what does this term linked data mean to you? So don't worry, this is anonymous. There's no wrong questions at the moment. Probably even invite some of the other panelists to join in. I'm sure they'll have different views about what it is. So before we start to unpack it, I wanted to get a sense of, when you hear those words linked data, what sort of things come up for you? I think you can contribute a few different times. Large administrative data, there might be a few other thoughts that people have and come up. So, like I said, it's anonymous. You can feel brave and if it's confusing and you don't know, put that in because I want to know that as well. So that's a good contribution. It is about large administrative data. That's usually what's being linked together. Unsure, absolutely. Outcomes data, yeah, it can include outcomes. It can also include things like activity and sort of, what's being delivered and done by services. So combining varied sources, relationships, yeah, good point. Correlation. So how do these things relate together and so on? Connection between databases, publicly available data, unsure. Shared data, privacy. Privacy is a good issue to raise and so on. Admin and administration, combined data sets, multiple data sets. Yeah, so I think everyone's coming in with a pretty good understanding of what we're talking about here, kind of a shared understanding. And we'll tease out some of these concepts, but I think everyone's certainly on the right wavelength and you're thinking about the right points when it comes to um, data linkage. So one of the things I wanted to flag is we will be looking at the chat and keeping an eye on the chat and addressing questions through there. Later on, we'll actually come back to using Mentimeter for some Q&A as well, because this is the kind of area where sometimes it's nice to have a bit of the ability to ask some anonymous questions, not have to pretend like we're all experts on everything, including myself. So feel free to keep that Menti window open because we'll come back to it later. One of the things that sometimes comes up, I'm conscious, is that we do tend to use jargon like data linkage and so on. But before we sort of get into the who and how and why you do it, I wanted to actually try and define these terms a little bit. So um, I'm conscious many of you will know about this, but I wanted to break down some of that jargon that we use. So the first step in the process is really figuring out who might have relevant information, finding the sources. The data linkers then, who are really authorized agencies, they're data record linkage organizations that help with combining data, they get involved at this stage. So the data linkers are usually organizations or agencies that were set up by governments, either state or federal, and their role is to help organizations combine data securely and safely, and importantly, to preserve people's anonymity. So we'll tease that out a little bit further. So those data linkers create a special anonymous sort of personal identification number to protect people's identities, is the idea underpinning that. And the data linker then asks for the details for people who've agreed to be involved in the study. Only approved information gets collected and combined, and it might be from these kind of sources like Medicare, NDIS information, hospital data, and so on. So the data linker does this matching process to then combine information from those different sources at an individual level while still keeping it anonymous. And so then we as researchers come along and we can get access to the data using secure computers. So the researchers, importantly, and I wanted to explain this, can't download the data about individuals. We can usually only run statistical tests on servers or these secure computers. The only things that we can usually download is the analysis. So for example, we could get information about the average length of time people might have spent in hospital, but we can't download individual information or information about why people were admitted and so on. The other thing to mention is that while it can take a lot of time and negotiation to do this initial linking, and that's, uh, that's quite a time-consuming process sometimes, but it can be, once that's done, it can be used to answer different questions. So we don't have to start from scratch each time. So I know that's a really simple explanation of what can be quite a complex process, but I often find it's really useful to remind ourselves before we get involved in the technical detail about what we're talking about. And I wanted to thank my colleague, Associate Professor Sally Nathan, for sharing those explanatory slides, because I find them useful to remind myself, oh yeah, that's what we're doing when we're doing linkage studies. So now what we might do next is move on to talking about some examples of linked data. So what that looks like can take different forms. So this is an example of something that's called the person level integrated data asset. And so this is something that brings together different sources of information that are held by the federal government, the Commonwealth government. And you can see that it includes things like, information on migration, disability, health, education, income, and so on. And they do that linkage process using those sources of information that exist at a federal level. But what's really important to note is that, again, it's really focused on federal agencies. And this is an asset that has taken a few years to pull together and negotiate. So we're really only starting to see some of the potential of this data asset being brought online now. The next one I wanted to talk a little bit about is a new one that's being developed and having more bits of information linked through it. And that's the National Disability Data Asset, the NDDA. So that really brings together some of the Bureau of Statistics information, health and welfare, and social service data, but is also starting to link it with some new and different forms of information, including information on health service use at state levels, education, maybe things that are new and haven't been linked before, things like housing and homelessness information, engagement with the justice system, and so on as well. And just to sort of round out some examples of what this linkage stuff looks like, another one that Margot, who's here today, and I have done quite a bit of work with, is based on the 45 and up study. So that's auspiced by the Sachs Institute, looking at 250,000 people across New South Wales as they age. They've now got 15 years of data on it. And importantly, it includes not just the linked administrative data from things like pharmaceutical records, Medicare, hospital data, and cancer data, but also they've done surveys at different points of time with people. And it also has some enhancements to allow analysis of information at like even neighborhood level. So you're probably wondering in that, how do we actually identify carers through this process? So one of the challenges is often, how do we identify carers? So one of the important things, and why I highlighted that example of PLIDA, that national one, and also the National Data Asset, Disability Data Asset, is that they've linked with some census information. And a really important question from the census asks about, in the past 2 weeks, did you spend any time providing unpaid care, help, or assistance to family members and others? So that's quite a functional definition of being a carer. And so that how people answer that can then be potentially linked with other sources of information. And so these new linkages, I think, are opening up a lot of new ways to think about and consider carers. Another example of a way we can look at identifying carers is through the 45 and up data asset includes a survey. So this is one of the questions they ask. Do you regularly care for a sick or disabled family member or friend? And does this person usually live or care? Does the person you're caring for usually live with you? One of the other things that we can do is try and rely on service records. The challenge there is that even when there is scope to collect or identify information about carers, it's not routinely done, and that even when there are these fields, the term that's often used, and you might have encountered it yourself, is a carer flag, like where there's a data field where you can say, yes, this person is a carer, or you can make the connection to the carer. That's not necessarily routinely done. And so as a result, it's not really, unless something's done routinely, it's not a really great basis to do linkage studies. But you can see with some of these new collections, new data linkage resources coming online, we do have the ability to draw on some of the more reliable sources to helpfully identify carers in new ways, in ways that haven't been possible so much before. And we'll explore what that means a bit later on. I wanted to give you an example of some work that I've done and Margot's been involved in and really led to give Margot her due, is an example of linkage research that's been focused on carers. So we did some work looking at the role of carers in Central and Eastern Sydney in Australia. To do that, we drew on the 45 and up study that I mentioned before. So it does have over 250,000 residents. Of those, over 30,000 identify as carers, used based on that survey information. That's then linked to over, 10 data sets that include state and Commonwealth information on health and wellbeing, over 172 million records, and over 20 million records for Central and Eastern Sydney area alone from 2006 onwards. So that's one of the really interesting features of this, is that we've got the ability to try and figure out what's happened to people over time and what some of the experiences that might be linked to the carer journey over time. This was done as part of a broader program of work that's supported by two local health districts in New South Wales, Sydney and South East Sydney LHD, and the Central and Eastern Sydney Primary Health Network. As part of that, they have an annual priority setting process, which really says, okay, for you as services, we've got these data resources. What can we usefully look at that can inform service delivery? As part of that, the program that Margot's led has really undertaken a range of work on different topics and different priorities based on those partners, including, importantly, looking at the health of carers. So, and that was really fueled by the recognition that there's a lack of understanding about the impact of being a carer on a person's well-being over time, particularly compared to non-carers in the Sydney context. I'm conscious that, there's been a lot of work done internationally on carers, but, that was a really important driver for the services involved. So what we did is we looked at some of those different sources of information, myriad sources of information over time, but importantly, including the surveys at different points about were you a carer or not? And we tried to understand transitions. So where people started out as carers and stayed carers, where they transitioned into and out of carer roles, and compared those, some of the outcomes for those different groups with non-carers. And also importantly, we looked at mortality, so the impact on rates of death as well. At a really high level, what we found was that around 12% of people involved in the study were that cohort that were being followed up by 45 and up were carers at any given time, but only 5% of people remained carers for all 5 years. So it really emphasizes that transitions into caring roles and out of caring roles. And that's a really significant transition for people. Within the Central and Eastern Sydney region, carers were slightly more likely to smoke, experience poor or fair health, so were self-reported help, similar levels of needing help with the activities of daily living, but had much higher levels of psychological distress, including have you ever experienced anxiety as well. When we looked at mortality, what we found is that carers versus non-carers, the mortality rates were similar, so there wasn't a big difference. But when we started to look at coping status, and the session before lunch was really interesting because it was about trying to identify carers who were having trouble coping as well. We found that, carers who weren't coping so well had higher rates of mortality. And that people who'd always been carers, oddly, and a little bit contrary to what we were expecting, had lower mortality rates as well. So we came up with a few ideas, but we don't have a good understanding of why that is yet. We think it might be about some of the activities involved in being a carer and the motivation to stay well as a carer as well. I'll just quickly check the chat. As if people have questions as we go, I am checking as well. So in terms of what this led to next was a follow-up study. We wanted to try and understand, because what we identified was that carers did have high levels of engagement with GPs out of all the services and service data that was linked. It seemed like people who were carers had good engagement with their GPs. And what we found through looking at that over time was that, particularly in terms of what was the relationship between GP engagement and hospitalisation for carers specifically, people who had that high level of GP engagement were less likely to be hospitalised over time. So really what we've taken from that and tried to inform service and service planning in Central and Eastern Sydney about is that those transitions between carer roles are critical points. They do occur. I know many of you on the line will have experienced that yourself. And that only a small portion of carers stay carers for a long time. And so there is this sort of sudden, commencement of carer roles. Oftenly, someone comes along and says, you are a carer, potentially after you've been fulfilling that role for a long time. And so you've got to quickly learn to adapt to these new roles. But despite that, carers are often well engaged with general practice, more than other people in the age range we were looking at. And so GPs might play a critical role in identifying carers, supporting and identifying carers who are struggling, and delivering some of the interventions that we know might work for carers. So that's a challenge in a setting where general practice is already feeling a bit stretched, but it does show that this is a really critical way of reaching and supporting carers. So, and it's particularly important for that group who aren't caring well. So I'll just mention that we have published some open access research on this, and that's available. We'll drop that into the chat. And I did want to acknowledge that the Central and Eastern Sydney Primary and Community Health Cohort resource is a consortium, and we have to acknowledge them for all their support, as well as the 45 and up study and the Sachs Institute and their partners as well, who've really enabled us to try and do a lot of this work. So some of the limitations and strengths I just wanted to mention after talking that through as an example of using linkage resources to look at carers and carer issues, is there are some limitations. Sometimes it can be tricky to identify unpaid carers, depending on how we're trying to identify carers. Relying on carer payments alone will mean that we'll miss out on a lot of carers. So that's why I think we do need to think about what other sorts of information can be used to help us identify carers. Unfortunately, linkage as it currently exists doesn't tell us much about the relationship or what's going on between the carer and the person being cared for. So that's a bit of a weakness. We would like to learn more about that. Administrative data can't answer every question, I think, is an important thing to note, and that time and resources are required to set up new linkages. But I did want to mention that many linkages exist already. We mentioned a few in the beginning, and we could be making better use of those. So in a way, it may be more feasible to try and interrogate some of those existing linkages, make better use of them than doing new data collections, and that linkage doesn't necessarily rely on people having to identify with their carer role. Unlike some of the challenges we sometimes face with surveys, is you might know people who clearly are carers, but for reasons of self-identification or, maybe some of their perception of how they're playing this caring role and so on, they might sort of not take on the identity or respond to the role or the name of being a carer. So this can sort of work around that. If we're asking people about functional questions, if we think about that example from the census, it's not saying, do you identify as a carer? It's talking about in the past 2 weeks, what have you done? So that can be useful as well. most link data is also longitudinal, so it can help us to understand people over time. It's not usually just one moment in time, and that many linkages might have the capacity to do analysis in terms of carers, but often haven't been used for that purpose. So I think there's some underutilized resources in this space. But I'm conscious that's probably enough from me now. I wanted to get some insights and share some of the perspectives of people who are in our expert panel. So I might get you to turn your cameras on if that's all right. Um, and what I wanted to do is I'll stop sharing screen now. Um, is to acknowledge that there's a comment from Northern Sydney Carer Support Service that perhaps the higher care engagement with GPs or primary care providers is more to do with the care attending the care recipient's needs and not necessarily their own. So I think that's a really good point. So in our study, we did find that. However, what we were looking at is the linkage for the carer individually. So I think even if they were attending primarily to support the person being cared for, they were also still getting an appointment there themselves. That's what we were picking up in the linkage. So I think there's something there. So even if they're motivated to attend for the person being cared for, the GP is still a really important link, I think, for the carer and not potentially sustaining them in that role as well. And I think you probably know and encounter that yourselves. So I did want to acknowledge Priyapon, Andrew, and Margot and thank them very much for joining today. Welcome, all three of you. Um, if it's all right, I might put you on the spot, Priyapon, actually, and just ask, what's a good example of a data linkage that's making a difference that you've seen?
This would be one of my work that I have done with people with intellectual disabilities. So we use the link data to understand the causes of death of people with intellectual disability who receive disability services, and then compare their death rate with the general population, and also looking at potentially avoidable deaths using the same definition as the one that AIHW suggested. And we
Mm,
found that you know that people with intellectual disability die more from potentially avoidable causes, and that trigger, not the trigger, that paper has been used in as an evidence for in the Disability Royal Commission multiple times to highlight the inequity that people with this intellectual disability receive. And another paper is using the same link data, but looking at how intellectual disability will identify in people who experience justice, in people with intellectual disability who went to jail. So
mm,
what we found is that the majority of people who had intellectual disability do not had no other services pick them up that as people with intellectual disability
wow,
before they went to jail. So
wow,
basically, they were identified as an adult, like in adult facility that they had intellectual disability.
wow,
And the saddest thing is when they were out, no one, like they did not receive any services that they would need. And that paper would actually um, got the commissioner has called Professor Julian Troller to discuss a way that we could actually do something to help provide the service that is needed for this population.
mm. So that longitudinal nature of the linked data, but also identified a real gap before people were. Andrew, I was wondering, do you have any examples or thoughts about linkage that you think has had a bit of an impact or yeah.
Yeah, I can give you a few examples, Ben. So in the early 2000s, there was a wonderful bit of research from Western Australia looking at deep vein thrombosis of people who'd been on long haul flights. And to have done that research other ways would have been incredibly costly and taken many, many years, whereas linkage was able to identify that link between people going on long haul flights and deep vein thrombosis very quickly
Mm,
uh, in comparison. So it used over like 20 years of data and was able to find an answer quite quickly. Um, some of my own work has worked with the then Commissioner of Ambulance in Tasmania, looking at out-of-hospital cardiac arrest, and that was the basis for a policy change in which when someone had a cardiac ar an out-of-hospital cardiac arrest, the nearest person, three people who were close by who had registered, would be able to be contacted because they would be able to get to the cardiac arrests quicker and use a defibrillator. So it was nearby where there were defibrillators. And that's now been used in New South Wales as well. There's the Good Samaritan program where people can register, and if there's an out-of-hospital cardiac arrest near them, they'll be notified and can use a public defibrillator. Um, just one other example. Lucas mentioned that I've done a lot of work with Australian Red Cross Lifeblood. So that was using linked data from the 45 and up study as well. And we're able to look at long-term health outcomes of blood donors in New South Wales. So again, if Lifeblood had set up their own study, it would have taken many, many years to do, whereas data linkage was a much more efficient and quicker way. And thankfully, we found there were no long-term serious health outcomes of blood donation, but it's also reassuring that that research had been done.
No, that's great. And Margot, what's your take on that as well? You know,
I think one of
your
the things,
experience. So I wondered, do you have some positive stories as well?
yeah, I think one of the stories that is worth highlighting is why the 45 and up study cohort was established. And basically, there'd been a lot of linkage work was starting to happen in New South Wales, but they didn't have the behavioural information, and they also didn't have things like whether someone was a carer, what people's perhaps their background was, what their capacity was from a daily living point of view, didn't have information about psychological distress, and also some of the conditions that were being that people were interested in, for example, like diabetes. A lot of that information is not in the linkage data sets. People have the condition for a long time before they're hospitalised. And so the 45 and up study was set up as a sort of a collaboration between government and various sponsors, including the Cancer Council, because they realised that there was a need for that information to complement the data linkage information that was available. Whereas quite often there's it will be the other way around, that somebody will start a cohort study and then think, oh, well, it would be good for us to also look at linkage data to complement it. So I think, if people look at the 45 and up study, there's a whole wealth of different research that's been done. That's, a lot of the confirmation of some of the smoking and the harms of smoking. We spend a lot of time looking at various, broad brush interventions such as care plans or it may even be some medications or even, some of the interventions like readmission for heart failure and having to look at seeing whether those procedures are working or not. And so any of the things that we're doing, if we've got really good measures, for example, knowing someone's a carer or not, then we can look at those aspects of it for carers and non-carers or carers with for example, what we did before where we looked at carers who weren't coping so well using that data.
And just to sort of, because I'm conscious some of the terms we use as jargon itself, what's a cohort for someone who's never thought about it?
I think, and look, a cohort is a group of people that you select, and sometimes it can be a cohort of people with a particular condition and you're following them forward, or you can, or a group of people with a particular exposure maybe, and you're following them forward to see what happens to them over time. The 45 and up study was a cohort of people who were aged 45 years and over and were then being followed over time with a combination of surveys to update the behavioural information, but also that linkage to the administrative data to also have that data as well.
Mm-hmm. And so, sorry, I was going to just follow up and ask, so from your perspective, maybe Andrew and Priyapon, what do you think are some of the advantages of linkage as opposed to some of those other forms of data collection that we might be thinking of for carers? Like we often do surveys or other collections, maybe interviews and so on. Do you have any thoughts about that, Andrew?
Yeah, so I think one of the big advantages is that you can get a whole of a population if there is data collected suitably that allows that identification of the whole of a population. And this is no criticism of studies like the 45 and up study, but there is a big issue about volunteer bias and so on. So people who tend to volunteer for those studies
Might be a bit
on
more
average are more
motivated,
healthy.
more well, or something like that.
Yeah. So I think that's a really big advantage. I think what you mentioned as well, Ben, about longitudinal data is an advantage. The efficiency. So instead of having to start a cohort study, for example, and wait for 15 years or however long an outcome might take, and some things, particularly with rarer outcomes, might take quite a long time until you get enough data. With data linkage, that can happen more quickly. I guess also sample size. It's much easier to get a big sample size in data linkage and much cheaper. And I think also, unless you're the ABS and you can force people to answer surveys, surveys are becoming harder and harder to do. And Margot can talk about this in more detail, I'm sure, but phone surveys are becoming extremely difficult to do. Online surveys, you get bots and
Yeah, that's interesting now, isn't it? Yeah, I've heard that that's a big challenge with, everyone's saying online surveys or, app-based stuff would be the solution to the going door to door or mobile phone surveys not working, people not answering their home phones. But now you're getting flooded by bots and so on. Priyapon or Margot, do you have any thoughts about that?
About the bots, I don't have anything about the
I
bot
know, just in
surveys.
general about the benefits of linkage and so on.
I actually agree with what Andrew and Michael said. Like it is cheaper to run data linkage at the same scale of the data that we've got. It's a lot cheaper instead of doing collecting new data by ourselves, and also is reducing some bias. I forgot what it's called, but in the population, for example, people with intellectual disability, when you know that they actually die at a faster rate, die quicker. So if you try to do a consent, like the study that require informed consent, etc., you will miss a lot of people. So you will actually have a call, possibly a survival bias, that people who are stronger, who live long enough to be included. So having having the data linkages helps minimize that.
I was just going to suggest, and that's very reminiscent of some of the issues that I know carers groups and carers researchers face, is that, you sort of carers have got enough going on in their lives. It's hard to sort of make demands on people's time, but also people who are new to the role won't necessarily see themselves as carers as well. So that transition stuff. Sorry, Margot, I think you were going to suggest something.
No, I suppose one of the things, and I think it's great that the census is including a question about caring. Again, one of the things with all of the administrative data that gets linked together is what pieces of information are missing. And so, for example, we're doing some more work now where we're using the Lumos data set, which is comes from general practice data. and that's then linked in with a lot of the health service data, so the the hospitalizations, ED, etc. Prior to that, a lot of the
And sorry, Margot, I was just going to suggest I didn't touch on that, but for people who are working with local health districts, they might have heard of it, or people who are working with primary health
Yep.
networks in New South Wales, they're trying to bring together data from those two sources, aren't they?
But the element with that is prior to that, we tended to use the medical benefits schedule data, and that really didn't tell us why people would go and see the doctor. It just told us that someone had been to see the doctor. And so again, getting more definition around, understanding better what's happening, and also it didn't have the results of tests. Sometimes it would say a test was done, but in this data set, we then have the results. So I think it's still with data linkage, thinking, does it have all of the components of what you want to look at in order to answer the question you're asking? And sometimes it doesn't. But in other occasions, you can answer most of the questions. But you've got to be able to define the populations well, and you've also got to be able to define what are the things that are likely to be impacting on it, as opposed to whether someone's a carer or not, or what the sort of complexities of caring are. And as you talked about before, Ben, the transitioning in and out of care, I think, is one of the elements that is quite complex. And certainly from a personal point of view, watching my father transition in and out of care when my mum first needed help, and then when my mum passed away, were quite traumatic elements of that carer journey.
Absolutely. Yeah, and
Sorry,
Priya,
Ben.
going to add to that. Yeah.
Yeah, so I just wanted to also add, like on top of what Michael said, is also to be mindful that the link administrative data doesn't decide for research. They decide for
Yes.
payment. So
Mm.
it's like it's as good as it gets, but we won't get, like Michael said, we won't know why someone go to
Yeah.
the hospital where they go afterwards. So that's another like.
And so, Andrew, I think you wanted to add to that, but essentially, it's sort of recognizing that there are some limitations that services are often collecting information because they want to know who's doing what, not necessarily the why of it, and sort of it's different to other research purposes. Andrew, what were you going to add?
One thing though that linkage can show is things about the coverage of different data sets. So many years ago, I was involved in linking police records of crashes versus hospital admissions. And what we found was that um, pedestrians and cyclists were particularly underreported in police crash data.
Mm. So
Um,
they were sort of essentially showing up in hospital, but not being reported by the
yeah.
police as
So
being.
even though there's a requirement if someone is injured by law that it's reported to police, often if it was a cyclist, for example, they wouldn't report, or um, or a person like just falling off their bike and so on. So it does sort of show up gaps in different data sets as well.
Mm, mm.
And
Which
I'm
is
just sort of thinking,
like similar to Prepon's story about, people with intellectual disability not showing up on any service sort of system before they ended up in jail potentially.
yeah, and that's right. And sort of in, I guess, more in disability and so on, you could look at hospital data sets versus what people say in the census versus NDIS records and get a more complete picture about, you know,
Yeah,
what's being covered in each data set.
absolutely. And where the gaps are and so on in practice. And
Just one other thing I
yeah.
think just wanted to add about an advantage is that um, generally health studies have looked at health outcomes and so on. And one of the great things I think about data linkage is that you can look at outcomes in different domains. So it might be and this is a euphemism, involvement with the criminal justice system, or it could be social security benefits and so on. So there's a lot of opportunity, I think, now, particularly with these new big data assets, to look at outcomes beyond what we call, traditional health outcomes. So education's another one. So I think data linkage allows, enormous capacity to look at those sorts of things. So in the, you know, perhaps for young carers, looking at education outcomes, do they go on to higher education, or their employment outcomes?
What's their sort of labor force engagement over
Yeah,
time? Stuff you can start to understand
as
that.
well as health outcomes. So I think there's a lot of ways to get more meaningful information about what's happening to particular people through linking various data sets.
And just because we're people with professional backgrounds in health and health research, it's not necessarily the thing that matters most to people in their lives, as carers and so on. So I think you've preempted something that I wanted to prod about, Andrew, which was, what are some of the opportunities that exist in terms of linkage with carers specifically? I think these new data assets are important. Do you have any other thoughts about that, Margot, Priyapon, Andrew as well? I do think we are at a sort of interesting point in time because of some of these new capabilities coming online and so on. What's your take on it?
So one of the other studies I worked on before I came to work at University of New South Wales was the Pathways of Care study. At that time, it was the Department of Families and Community Services, now Communities and Justice. And of course, that was linking data, identifying a cohort of children in out-of-home care. And part of that process, part of that was understanding, so you have a population that's sort of defined within the department, and then linking. And so then that was being linked to their health records, education, a whole range of other different data sets. And again, there are, various groups within the population that we don't know a lot about, how their outcomes. Some of the outcomes for children out of home care were not particularly good in the short term. A lot of them, as they transition out of care, can be quite traumatic, but also looking at that longer term. But also that's nearly an action research type method where whenever you found something that was problematic, by doing this linkage as you were going along and also having, complementing it with other, more in-depth information, meant that you could make a change then and there and improve the services that were happening. So sometimes that embedded type of research is quite
some sort of
important.
opportunities to really start buddying up between some of these organizations and the kind of linkage studies we're talking about. Yeah.
And just with the Lumos one that I did mention, I think one of the benefits of that is the data sets are sort of in collaboration with the New South Wales Health, as well as the primary health networks, which are funded from federally, that sort of link between the different services with the primary care and the state. The difficulty in that data set is there isn't a variable that talks about carer, being a carer or not, which again, the opportunity there would be a change in the general practice system, or there might be, people might be using different fields, but it's just not being able to be extracted. So sometimes it's a minor change that will allow you to be able to use the linked data in more innovative ways if you've got that extra piece of information.
Priyapon, you
Yeah,
keen to say something?
I just wanted to add that some opportunities I can see that just recently been available to us is through the National Disability Data Asset, because it bring the domino. So people who receive is it pension, receive some money, some government money to be a
Benefit.
carer. Yeah, the benefits from the government, plus people who identify themselves as a carer. It could be unpaid or could be paid. With that one, we can actually look through how, like, let's say if they only identify as the carer, unpaid carer, but with no money, whether there are any differences in their health outcome or not. Because I know from my family experience that unpaid carer actually had a really high burden of psychological burden, and this data set, the NDDA, because it's all a spectrum, you can now look at the younger carers and what happened to them, because in the past only 45 and up was available, and then so your carer is a bit older. This time we could see the
Mm.
broader spectrum.
Andrew, what's your take on that?
I was just going to add just something to what Priyapom was saying about being able to look at younger carers. I think there's also big opportunities to be able to look at Aboriginal and Torres Strait Islander carers, because even in studies like the 45 and up study, it's, the numbers start getting quite small. Also, like people from multicultural communities or cold backgrounds, we can use the census data, which has better information about people's, ethnicity and so on, to look at that. The other sort of big advantage, I think, is that we can also get really good information about people's socioeconomic status now, in some of these data assets, which in the past, unless it's using a survey like where there's a questionnaire like the 45 and up study, what you can do using these big data assets is get people information on people's individual socioeconomic status, their education, and so on. And really look at, I guess,
So to sort of tease that out, like practically, Andrew, like in the past, it might have been, what do we know about how rich the suburb you live in, as
yeah,
opposed to now we can sort of say at an individual level
yeah,
what your income is.
and even within rich suburbs, there are people who are not so
Oh, absolutely. Yeah.
rich and so on. I guess the other thing is also that it gives us, these data sets give us a good insight to what happens when someone becomes a carer as well.
Mm-hmm.
To those sorts of, to their income and so on.
What happens at those transition points to get a
Yeah, so they, as everyone on this call knows, people might reduce their employment hours or leave the formal labor force, for example. So we can see that sort of thing. The the ABS is also releasing a module in some of its data sets about identifying relationships within households. So I think that's also really important. And the last thing that I'll say is that I think what we can also look at is carers for people with different care needs and so on, so aged care or caring for children or someone who's has
someone with a
dementia or
specific
cancer.
disability or type of
Yeah.
disability. Yeah.
And comparing across those.
Yeah, to try and differentiate what's different about the experience, but also what different points of support they might need.
Yeah.
Yeah, no, that's some really good points. Margot, I'm conscious you probably want to chip in, but there was a great question I thought that's a little bit related in the chat. I'd love to hear from the presenters about some of the ethical issues about big data or linked data and how these can be addressed. Andrew, I think you sort of nodded your head to some of that in terms of, the experience maybe of Aboriginal carers or people from First Nations background, culturally diverse groups, how to do that ethically, particularly when we're talking maybe about smaller numbers of people where we might be challenged about identifiability, but also some other ethical issues that might come up. So I just want to acknowledge that's a great question. I don't know, Mark,
Do you want to
in
ask?
relation to that or the things that we were talking about before?
I think the ethical side is really important. generally, when there are large linkage data sets and large linkage projects are done, researchers get a waiver of consent that they, because these are large linkage data sets, they still have to get ethics approval to do the analysis, but they don't go out and get consent from every individual who's contributed. So the custodian of that data is actually providing that sort of consent in some ways on their behalf. For something like the 45 and up, where it was a cohort study to begin with, people joined it, gave consent, but cohort studies can really only be linked to administrative data collections if the people have been asked, are you also happy to give consent for your data to be linked to these other, administrative data collections? And that can be a quite complex question to ask someone when you're, asking them to join a survey, and particularly the, say, Services Australia, they have for the, the primary care data, the MBS data, and the pharmaceutical data, they have a script that researchers have to use for consent for the people to be linked there. Other, I suppose, custodians or data linkage facilities will look at your consent that you're asking people and check whether that's appropriate for the linkage that they've done. So it's certainly something that's complex. The other part from the linkage point of view is often once you have linked lots of data sets together, even though the people's names and demographic information, there's names and addresses and everything aren't on the data set. Once you get quite a few pieces of information linked together, people can become identifiable. So a lot of these large linkage resources and data is then analysed within secure data environments, so that researchers are able to take the results of their analysis out, but not be able to take the unit record data or the people's individual records outside of that site.
But to make that really comprehensible, because sometimes that can be sort of like the magicians in the back room sort of stuff. Essentially, it means there's sort of like a server running somewhere. You can run things on the server. You can do your percentages, your frequencies, or other statistical tests. You can get it to tell you that stuff. You can't get it to say Margot earns this much or lives here or that sort of thing. You can't get that kind of information. And pre-upon then, Andrew.
So I just gonna add, I am also ethics committee for New South Wales Population Health Services, so I can offer some input on the waiver of consent. So we at our committees, we are very strict. So all the variables that is required, like that the researchers requested, we scrutinize and say whether it needed or not. And some variables, let's say, for example, date of birth. Most of the time, you wouldn't get the exact date of birth. You will only get month and year of birth, for example. And that is another part. And also, we also have another legislation. If you are using Commonwealth, like the government, Australian government data, like medication, etc., AIHW, the Australian Institute of Health and Welfare, are our sole curator. So we have to use what Margot referred to as a secure environment to do our work. And before we can output anything from out of that secure environment, they will go through it. They will comb through our results, making sure that we don't have anything that people can notify. Let's say I can't say, like, in 2024, there were 4 people receiving procedure X in New South Wales. That would not get out of that. Another thing that is required for people to do the link data, whether it's going to be a waiver of a consent or whether you have a consent, is that what we call a separation principle. So researchers like Andrew and me will not get the identifier. We will not have the access to name, address, etc. of the people that are in our cohort. What the identifier that we only have is the unique random number that AIHW or any linkage unit in the state generated for us.
Yeah.
And the identifier will be kept with Cheryl and with AIHWs, and there is no way we can link back.
So just to sort of, because I'm conscious we chuck lots of acronyms at, AIHW, the Institute for Health and Welfare, and Cheryl is the Centre for Records, Centre for
Health record
Records
linkage.
Linkage. Yeah. So, and that's a New South Wales state agency. So, Andrew, I'm conscious you wanted to chip in, but we've also got some great questions coming through, so I want to check in with some of those as well.
Yeah, I just also wanted to add that the federal government, for example, does a lot of data linkage anyway. So,
they're combining your information anyway.
Yeah, and these things are all set up where they have to sort of be done in, the public interest. Whereas other things, so robo-debt's a classic example of data linkage that probably didn't go right.
And probably didn't have the kind of ethics protection that you've been talking about.
Yeah. And so, for example, Ben, if you go and buy a Lamborghini this afternoon, which I know you're planning to,
sun's out.
the New South Wales government will report that to the federal government, and that will all be linked, and they'll be asking how does a university employee who's not a vice chancellor afford that Lamborghini. So so I think people do. I think the ethical concerns and privacy are very legitimate, but these things are happening anyway, and I think that there is really they have to be done for the public good.
And that's, I think, sort of a good argument for why we do need to do it ethically, why there do need to be ethics processes and reviewing it and stuff. But if this kind of linkage is being done behind the scenes, Robodebt, like a fantastic example, it'd be better if we can ensure it is for the public good and elevate the sort of the standard and the ethical conduct required around linkage projects and so on. Yeah.
So I was just going to say, Ben, one of the earliest kind of linkage that happened was linking people within a data set, and for something like hospitalizations, and before linkage was done, we would be reporting on the number of attendances that happened or the number of discharges from a hospital, but we actually didn't know how many people had gone to that hospital. And so linkage,
you couldn't figure out if it was the same person 100 times or 100 people.
Or was it 100 people once? So a lot of that early linkage work sort of was done, where we were trying to improve the quality of the information within the administrative data collections. And then from there, the obvious thing was then joining those pieces together. And so I think there's, it's been quite a long journey in linkage, but I think that's really been a benefit because along the way, there are all of the checks and balances that have been going with that. And government was a bit reluctant to let researchers first use that, those linked data sets, whether it was data sets that had the internal opportunity to internally link, or once you're able to link together. But now there are, very good, linkage facilities that allow that to happen. And often those facilities they have these sort of master linkage keys, so you're not having to, the people's information where they're linking it together is not having to be done multiple times. They've got
so that special number is
that special number.
But we can't sort of backtrack it to figure out who it is.
Yeah, that's all held quite separately to where the information about the person is held. And then that's the information about the health or whatever the research question is held somewhere very separate.
Now, I'm conscious we've been getting into that in a little bit of depth. One of the questions which I really appreciated was I'd like to ask the presenters, how can an early career researcher approach and access these big data sets? If I'm starting out, how do I get involved with some of this? Because we hear about these things existing, but it can seem a bit daunting, concerns about what do I need to know? How much is it going to cost? Who do I go to? What's your thoughts about that? Maybe Priyapon, you've had to wrangle this yourself a few times. You know, how would you get started if you were an early career person or starting out in this area?
Um,
Or even if you're maybe a community agency who was interested in working with someone about this, how do you have any thoughts about how you'd?
so there would be multiple angles I could look to. If you are a early career academic staff, I would say if you want to work at data linkage, look at the profile of people in the field that you want to work and to see whether they have some people who do link data, because even though it's
Make friends with
statistics,
people sort of thing. Yeah.
yeah, even though it's like it's statistics, but a link data requires special skills, like not so much about stats, but require a lot of special skills to do the data manipulation, etc.
Knowing how
Also,
to make do the
yeah,
stats
do
on
the stats, like
your
how to,
environment and so
yeah,
on.
how to
Yeah.
get the data into the right format to be able to do anything. That is the most critical part. So I would say you possibly need to like make friends, like what Ben said, with people who actually doing it day in, day out. And there were multiple courses that you could attend. Like USIT has some, University of Sydney had run 2 courses a year, I think, for the health data linkage. And then I know that UWA, University of Western Australia, also run some good courses as well. And yeah, just like asking people who you are working with, hopefully there would be some senior that could providing you with some hand-on experience,
Mm.
because your code would be unique to what you are doing, and not no other people cannot, like you can't copy anything.
Yeah, yeah. No, I was just thinking that's a great example, and I'll get Margot's perspective, but maybe in throwing to you, Margot, just sort of relate that, you know, my own knowledge of linkage is pretty naive and so on. So I made friends with Margot about some of this stuff. We thought, oh, this might be useful for, you know, interrogating some information about carers and so on. So that kind of, if you've got an interest and maybe you've got people you might be working with and so on, you've got an issue that's important. People who are involved in linkage are often quite keen to work with people. I mean, what's your take on that, Margot? Was that
Yeah,
yours?
no, definitely. The other thing, of course, and one of the papers that Ben highlighted was a fifth year medical student that did it as his independent learning year. And so we like having students or early career researchers working with us, and often you know, data linkage teams do. The thing with it is often, you know, often there are unlimited possibilities of what you can look at with these linkage data resources. And so having people exploring things, of course, they are complex. And so often when you have a data linkage resource, you'll have a data manager and a statistician who's there to provide you advice. But I think if you're an early career person or you know, wanting to do PhD studies or something, then it's a great area to get into. And really some of the analysis, some of the stats, once you've got the data in the format that you need it in, then the analysis is not too difficult. It's often getting the the data the way you need to. Just one quick example, we got some integrated care data from some admin data that we hadn't seen before. And when we first looked at it, it looked exciting because there were 60,000 records there. Once I got rid of the duplicates out of it, and it often was these different items and different sort of ways, things that were being recorded about the person. But with regard to the people, it came down to 500 people. So often in linkage data, you have a lot of detail there that you may not need to use in your analysis because you have every time that that person has interacted with that service as part of the data set. So it's often, so we're often counting events or first time that somebody has done such and such, or number of times that they've had a service, or so often that's the hardest part of the analysis, is often getting to the point of, how you're going to use the data before you do the analysis.
Can
And
I
also
add?
an insight into why people might not have looked at the data in terms of carers, for example, even if the link is.
Definitely, yeah.
So, Priyapon, you were going to say something then, Andrew?
Yes, sorry. Can I just add one more point on that one? Another thing that possibly you should also be friend with people who provide you with the data, because how many times that I have to go back to, like, if you use the data that is outside of the unit, data linkage unit. Let's, for example, I use the data from disability minimum data set or with the corrective services data. They don't have data dictionary.
Mm.
And so data dictionary is a term we use that people might not have come across it. Essentially, it's a way of saying, imagine you're looking at an Excel spreadsheet, it's the columns, essentially. It's like, this is what's in this column. So, and if you don't have dictionary, it's almost like having a column with no header, basically, isn't it? You don't know what what values can exist in that field.
Yeah. So that's many times that you have to go back to them and like, okay, I know this is the table about demographic, but what are they? Or something like that. So that's like another thing that you need to think about, like.
Yeah. And that's a great tip and great point as well. Yeah, at just a very practical level. Andrew, what's your take on this? If you're started.
So I guess just to add from a different perspective, some of these new data assets are not prohibitively expensive in terms of accessing them. Sort of talking probably about $10,000 a year, which includes access to some of
Sounds like a lot, but if you compare it to, say, doing a significant survey of a lot of people, it's
so a really big survey would cost a lot more, or setting up your own cohort study would cost, they cost a fortune, essentially. But I think it's really the person time to get the permission and then do the analysis and so on. That is very expensive. With the National Disability Data Asset, there's also a requirement that all outputs are made in accessible format. So that's also one other cost that needs to be borne in mind. So that's in Easy Read and some other formats, Braille and Auslan. But yeah, I think in terms of expenses and so on, the real big one is really the person time for
the
analysis.
time to do it. Yeah.
And then writing up and all those sorts of things. But
No, that's really useful. I've had a question in the chat, which is about saying, is there anything specifically targeting people who are carers for multiple people, like sandwich carers, where you might be caring for young people as well as like maybe someone aging and so. I think that question is probably highlighting one of the challenges that we face with a lot of linked data, is that we can't get a lot about that carer and person being cared for relationship, which is critical. A lot of rich information there, but it's something that probably linked data at this stage is not so great about capturing that sort of relationship between the carer and the person being cared for. There was a good question though also about
if I can just make one point, then one of the things,
just one, Margot, just one.
Just one. The 45 and up study did, and this is an opportunity people can ask for sponsored questions. And so in a wave of data collection, you can add some questions. And in one wave, they added a question about, are you the carer of somebody who has dementia? So it was only if somebody said they were a carer, they then asked. So it wasn't linking all of the information about, the person, but just asking a specific question. So there is the opportunity to do that. And look, with the 45 and up data, there's the opportunity to go and, ask other people, ask more questions of those people. And more recently, they've just announced, and I don't know a lot of details about it, that they're going to do a a survey of, other people in the families, the sort of next generations, similar to what they did in the Framingham survey. Framingham sort of survey was a big cohort study in the US, where they then did an intergenerational one. So, I suppose watch that space. That might be an interesting one. One of the nice parts, Ben and I in the past have had the opportunity to feed into what questions are being asked by the 45 and up studies. So, a lot of researchers, because it is a resource that researchers can use, can try and lobby for what should be in there.
Now, I'm conscious a little bit of time. There is one last question I just wanted to check, maybe just perspective from each of you. A lot of the research is focusing on big outcomes, like hospitalizations, mortality. What about everyday outcomes or longer term ones like well-being? Do you have any thoughts about that? One of the interesting things I think about linked data is there are a lot of different data points, so we can get information almost on the everyday in some ways. What's your take on that?
I'll start because at the moment it's kind of the limitation of the linked data that we don't record the well-being of a person, like the quality of life, etc. For example, at the moment is not part of the data linkage. Most of the time, we only know when someone will admitted to a hospital or die. So that's why it is what it is currently. But possibly with the new, like, with the census data or something, we could possibly tap onto that at a later on, but the data is still new. You would possibly see more in the near future of all the research publications.
What's your take on that, Andrew? Do you have a thought on that?
Yeah, so there are multiple instances of the census available in PLIDA. Which is
that's jargon again, like to just to pack it to sort of
which is one of the
means that you can find out what Andrew said in the 2021 survey, the 2016 survey, the 2011 survey. Does that sound? Yeah. And then say, how you've answered differently over time, potentially. Yeah.
Yeah. So I guess that's one opportunity. But I think the rich variety of data sets as well can give quite a bit of information about that. I guess this goes back to some of the limitations is that most of these data sets, but not all of them, are related to payments or, routinely collected data that are generated by events. So, someone
did something,
or got a prescription and so on. So it is a big limitation with a lot of these data sets. You don't know if it's about people having different access or not having that need.
Yeah. So you got to be careful not to overinterpret, what's going on. Is it?
Yeah, so you might find some people have a high rate of emergency department presentation, but that might be because they don't have as good primary care, for example. And how you interpret that is very difficult.
But I think that's also the strength of data linkage when you've got the primary care and you've got the hospital data there or the ED data where you can be looking at all of them at once.
Yeah.
Whereas if you're just looking at the ED data, then you don't know whether the people are it's because of a need or if it's the that we just don't have that information. I was going to say, Ben, just your quick if I can do my quick answer.
Yes, of course. Sorry, and the reason I shared the screen was just I want to capture people's ideas at the end of this session about how you'd like to see people using this from now. But go ahead, Margot.
So one of the things I was thinking, and where you have a cohort or a survey that's associated, and even the census, it's every 5 years you might get asked about quality of life. 45 and up is a similar gap between each round of data collected from individuals, and so it's not very fine line. It'd be nice if as part of our primary care data collections they were including something like, how's your general health going, how's your life going, and for that type of information to be there, as well as the more medical information. So that's something we can certainly be lobbying for. It's about the whole person, not the condition.
Absolutely. Absolutely. Yeah. So just sorry to be to slightly interrupt earlier, Margot, but the reason I've shared the screen is that now, but also after this session, I'd love to get people's ideas. You can drop as many thoughts in there as you'd like about how would you like to see government or services or researchers like us using data linkage to support carers specifically. So if you've got any thoughts, please drop them in the Mentimeter. I'll make sure that that gets conveyed to Carers New South Wales and so on. And, feel free to do it now, but also after the session as well. Andrew and Margot and Prepon, I wanted to give you just a brief chance to sort of reflect, or just your final message that you'd like to sort of impart before we end the session.
And maybe I can start. I just think this, and I think it's a little bit, we're at the beginning of a journey with regard to what's possible to better understand how the interactions, I suppose, how data linkage resources can support carers. And I know when Ben first approached me about doing some of this work, he'd done some, in-depth interviews with carers to better understand what was, what the issues were, and trying to inform things. And what we wanted to do was look, well, how look at it from a larger perspective, and the linkage data was a great way for us to do that. But I think all along the way we've identified limitations, but in some ways I think our main limitation is having carers recognise more in a lot of these administrative data collections. And so whether and I think there has been some work in New South Wales Health where that is the case, so that if someone's at the hospital, they know whether that person has a carer or not. But I don't think it's very well completed at the moment.
Andrew and Prayerpon, what's your final thoughts?
Look, just add to what Margot was saying. I think actually we need to start analysing some of the data, because then some of the issues will become more apparent. And I think through identifying some of those issues, that can be a good way to lobby, as Margot said, the better inclusion in different data sets. I guess the other thing that I would add to that is that although we don't know exactly how good the information is, I think what we can do now is much, much better than what we could do, even a couple of years ago. And I think, as Margot said, I think this is really the start of some really exciting research that can really inform carers, policies and programs and so on. And Ben will be shocked to hear me say this, but I think it, also needs very strong consumer involvement in terms of the questions that are being asked.
Really elevate the carer voice in setting the agenda.
As Ben knows, I just like to play with numbers usually.
And Prayerpon, what's your final thoughts?
Yeah, I agree with what Marco and Andrew has said. And again, like the data linkage, the result from that is just a tool. Like the questions come from the consumer reference group. In this case, it's the carriers that we are providing the tools for people to advocate or try to highlight what are the areas that need to be dealt with. It's not be all in all in this one.
No, that's tremendous. And I think everyone will have gotten a sense from this session that there's some limitations with linkage data, but even taking that into account, The insights it has to offer are exciting. There's some big changes afoot. And I think linkage can tell us a lot about the experience of carers without asking carers to do more, which is a big challenge often. We're stretching people who are already stretched, and that the carer's voice needs to be elevated in a discourse and understanding of this and so on. And so thanks very much for everyone who's included some of those ideas about how you'd like to see more work in the linkage space. I'd like to really thank the panelists for their generosity and all their time and so on. And I'll hand over to Lucas probably to close the session. So thanks, everyone.
Thank you so much, Ben. That was a very interesting and very detailed session. I will take your advice, Priyapon, and we'll all try to make friends with people who work with big linked datasets and get carers early into the research process to add their voice so that the right questions get asked of these datasets. And that's another great quote, Margot. It's about the person, not the condition. And I would like to add, and to the person, we should look at the relationships and the caring relationships that might not be apparent in the datasets, but they are there. So thank you so much for this incredibly insightful session. For everyone here, take time and look after your well-being if this session has touched on anything that might be stressful for you. On your screen, you can now see some well-being resources. Please take the time and take care of yourself. And I hope to see as many of you as possible at tomorrow's sessions. And thank you. This was a very intense and very insightful day. And see you tomorrow.